Good morning or good afternoon. I'm Monica Pica with Sachs Healthcare, and I will be your technical producer for today's webinar. Before I introduce our moderator, Dr. Susan Pyrus, and our speaker, Angela Craig, I would like to review a few housekeeping details. Today's webinar is being recorded. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. If you experience technical difficulties, please use the Tech Support tab, also located on the right-hand side of your screen. And if you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen if you're using a PC, or Command R if you're using a Mac. And please make sure you are not behind a firewall, as this will prevent you from viewing the presentation. Our moderator today is Dr. Susan Pyrus. Dr. Pyrus is an Associate Professor of Nursing at Witson-Hester School of Nursing at Tennessee Technological University. She earned her BSN from Cedar Crest University and MSN in Nursing Education from Duke University, 2010, and PhD in Nursing from Vanderbilt University, 2016. Her graduate and terminal degrees focus on nursing education and nursing research. Dr. Pyrus's clinical background is in critical care nursing and specializes in innovative teaching strategies, critical care nursing, and nursing research. Welcome.
Good morning or good afternoon. Thank you, Monica, for that very kind introduction. The title of our webinar today is Sepsis, the Hemodynamically Challenging Patient. Speaking today on this very timely topic is an expert in this area, Angela Craig. Angela Craig is a clinical nurse specialist at Cookeville Regional Medical Center in Cookeville, Tennessee. She has been a clinical nurse specialist for over 25 years, and the last 15 years have been in the 28-bed ICU at CRMC. She chaired her hospital sepsis team and led them to be the first specific sepsis disease certified hospital in the state of Tennessee. Additionally, she is on the Sepsis Alliance Advisory Board. She has worked with area nursing homes, long-term care facilities, home health care, and EMS to increase early identification of potential infections and effective interventions. Our speaker has disclosed the following financial relationships. She's medical science liaison for Baxter Medical Affairs. She's on the Sepsis Alliance Advisory Board, and she is an independent consultant. This activity has been approved for continuing education for nurses and respiratory therapists. This educational activity is approved for 1 contact hour, and at the conclusion of this webinar, a link will be provided to obtain your CE credits. Support for this educational has been provided by Philips. And at this time, I would like to turn the presentation over to my colleague, Angela Craig.
Thank you, Sue. It's so awesome to be here today. We are going to talk about this hemodynamically challenging patient, the sepsis patient. And if you've cared for a sepsis patient in the intensive care unit, then you know how challenging this can be. So we're going to get right to it. Our objectives today are really to review the importance of a reliable monitoring system to help us treat our sepsis patients. We're going to talk about the use of hemodynamic variables to assess and treat those patients. And we're going to review a sepsis case study to try to integrate those hemodynamic variables and hemodynamic monitoring to try to maximize our best outcomes. I was just talking with a colleague this morning. Isn't it true that really what matters are patient outcomes, right? That is our importance and our focus as patient outcomes. So I'm going to turn this over to Monica for our first polling question.
Thank you so much. Please make sure you're not in full screen mode in order to participate in the poll. It will appear on the right-hand side of your screen. And the poll reads, what is your current role? We have several to choose from. Please choose the best answer. Is it staff nurse in the hospital, sepsis coordinator, quality department, clinical nurse specialist, nurse educator, provider and PPA doctor, or other. So we'll pause for just a moment, and we certainly appreciate you all being here, and thank you for joining in our poll so we know who's out in the audience. So once again, what is your current role? And I'll give it just another moment before we close out that poll. And then I will turn it back over to our speaker. Thank you all so much. Back to you, Angela.
All right, thank you. And for those of you who are other, I saw quite a few others. I'm curious to know what departments you work with. That would be great. Okay, we are going to get on to the content. So I want to mention Happy Sepsis September, right? Happy Sepsis September, Happy Sepsis Awareness Month. I would have been presenting a lot on sepsis this month, and I thought it was so funny last night. I said to my husband, oh my goodness, I am tired of hearing myself talking. And he said, well, how do you think I feel? Okay, so that was our little icebreaker. I'm grateful to have a good husband. He does listen to me a lot. But anyway, it has been a busy month, but we are going to continue just talking about how we can impact the sepsis patient population better. So what is new in sepsis? I wanted to share this with you from the very beginning because we all know, or if you don't know, I'm going to share with you that sepsis, the core measure sepsis, has been chosen to be part of value-based purchasing. Now, value-based purchasing is with the CMS, so Centers for Medicaid and Medicare Services. And what that does is it determines if you do well with a core measure, you may get reimbursed. If you don't do well, you may have to pay back. So this is definitely a massive financial change, right? And so I want to explain a little bit about that. So each domain is for value-based purchasing is in a different color, as you can see. And the weight of each domain is listed on that far right side. So you can see that each of those domains are worth 25%. Note that the sepsis area is in the purple safety domain. Now, the baseline period is defined for each measure. So note that the baseline, I'm going to mainly focus on sepsis here since that's what we're talking about. So the baseline period for sepsis is January 1 of 2022 through December 31 of 2022. Well, guess what, folks? That's over, right? We can do nothing about that information because it is already set. Whatever you did, the year of 2022 is done. However, next slide. The performance period is defined also for each measure. So you have that baseline period, but for sepsis, the performance period is January 1, 2024 through December 31st, 2024. So game on, right? That's right around the corner. And what they'll do is they'll compare. And based on which you do better, you have an opportunity to improve. So it may behoove you to go with your 2024 data. So let's talk through this just a bit more. One thing I want to mention is that for the fiscal year 2025 for CMS, that is October 2025 to September 2026. So this will be an annual review / payment process, right? We will then advance the baseline accordingly. So then you move everything a year later. So we had 2022 baseline and a 2024 performance, then that will impact 2026. And so the following year, it will be 2023 baseline, 2025 performance, and then review of payment 2027. Right now, this is going through 2030. So it looks like we're all going to be abstracting through at least 2028 for step 1. Now, it could increase. It just depends. It may change. So when we think about the achievement threshold, how it's defined for each measure, right? We kind of talked through that. A hospital score must be at or above the achievement threshold to obtain those achievement points. So note that for sepsis, the achievement threshold is 0.5 597,482, which is slightly above the current national average of 58%. Now, remember that a hospital with a lower score still has the chance to earn improvement points if there has been improvement between that baseline period of 2022 or the performance period in 2024. So CMS will use the better of the achievement or improvement scores for that measure. So game on, everybody hang in there. Everybody hang in there and work hard, because hopefully you'll gain some points there. Okay, so the benchmark then represents the top performance standard for the measure and reflects the national top decile performance. Okay, so you're going to see that the benchmark is very high, as you can probably see there. So anyway, that is just information that I wanted to add to this presentation, because many are dealing with this right now in the hospital, right? So let's go right into the pathophysiology of sepsis. I think it's important that we understand the pathophys so that we can understand what's really happening at the cellular level. So if you notice, homeostasis is unbalanced in that patient. We have an increase in coagulation, an increase in inflammation, and a decrease in the breakdown of fibrin at the microcirculatory level. So let's look at it this way. You can see here, this is our impaired coagulation and impaired fibrinolysis in severe sepsis. And what we have at the bottom here, you see this inflammatory response to the infection. And then you have the coagulation cascade that's innervated. We're not going to talk about every one of those factors, but then you can see down here these fibrin to fibrin clots. But then you have a release, and I'm going to go to this next slide, where you have the release of this PAL1, and it suppresses that breakdown of fibrin at the microcirculatory level. So what you end up with is like fibrin clots in the microcirculatory system. So what I want to show you is that because of those microcirculatory clots in the microcirculation, you have a decrease in perfusion. Decrease in perfusion can cause different shock states, and that's what we're going to talk about, because notice you can have almost every shock state with the sepsis patient. Now, I know this is a busy slide. I'm not going to go through that whole algorithm, but you can see the different shock states, and these patients can go through that. Now, when we think about the different shock states that these patients go through, the first one I want to mention is distributive. And I think most of the time when we think about sepsis, we think about distributive shock, right? So there is this dysregulated immune response to the infection, and you have this massive cytokine release. And what that cytokine release does, you have vasodilation of your vessels, and you get very leaky capillaries. So with this vasodilation, we end up with a very low systemic vascular resistance or total peripheral resistance. You end up with a low diastolic blood pressure that we'll talk about, and a low shock index. And then you end up, your patient's hypotensive, right? Another type of shock that these patients may have is cardiogenic. How many of you have had patients with severe sepsis or septic shock take a hit to their to their cardiac system, right? Where maybe they just don't have the contractility. Maybe you do an echo and you find that their ejection fraction is down to 20% when normally it's normal. This happens so frequently. So you end up with this myocardial depression, and that's really related to this cytokine storm, right? The release of all the cytokines. And these are drivers of inflammation and myocardial depression. They're released. You have tumor, necrosis factor, and interleukin 1B that's released, and all of this plays into this cardiogenic shock. You also have nitric oxide and oxygen-free radicals that are secondary effectors of myocardial depression and septic shock. So you definitely have the opportunity to almost have every shock state with your septic patient. Hence why we need to hemodynamically monitor these patients. And then last but not least, I maybe should have volemic shock. Many of these patients are intravascularly volume depleted. Sepsis hypovolemia related to diarrhea, related to vomiting, related to tachypnea, related to sweating, decreased fluid intake. All of those can cause the hypovolemic shock. And then ultimately, with all three shock states, many times end up in the hospital. And they're looking to us to be the leaders to care for them, right? What can we do to better treat these patients? So this is microcirculation sublingual blood flow. And so when we think about pathophysiology, I'm just going to go ahead. Actually, the link, sorry about that. The link's not working and there's no problem with that. But basically what you have in this microcirculation sublingual blood flow, it's like blocked up at the microcirculatory level. It almost looks like a backed up freeway when you look at the blood flow. So what we have is this imbalance of oxygen supply and demand. And so what can we do to make that better? Well, we first and foremost need to have a reliable monitoring system, right? Whatever you have as your main cardiac monitoring system, it needs to be reliable. It needs to be accurate. We need to have the ability to utilize these hemodynamics at the bedside. So we have to count on that accuracy. We need a system that assists us in rapid assessment and intervention. When you think about those patients, for instance, with the cardiogenic shock, being able to look at the monitor, being able to know, hey, do we have ST segment elevation or depression, or is there something going on cardiac-wise with this patient? We're going to talk about some of the elements too that we can utilize with a good cardiac monitoring system. And then most important, as I've kind of mentioned earlier, assisting in improving patient outcomes. That is so important. And that's what's the most important of all, is we want systems that help us improve patient outcomes. So we are going to review some variables that we could utilize with a reliable monitoring system. Now we're going to start with another polling question, and I'm going to turn this back over to Monica.
Thank you once again. That poll will appear on the right-hand side of your screen, so please make sure you're not in full screen mode in order to see and participate in the poll. And you can certainly click the radio buttons that are on your on the poll itself. So the poll reads, do you currently use end-tidal CO2? So it's a simple choice. It's yes, we routinely use, or no, we use in special circumstances. And the next one is we use in special circumstances like post-op or with certain medication infusions, and the third choice is no. So it's yes, or we use in special circumstances, or no. Again, thank you all for being here today and for participating in the poll, and we look forward to reading your answers and discussing the results. And I will go ahead and finish that poll in just a moment here, and then I will turn it back to Angela. And thank you all for participating. Angela, back to you.
All right, thank you. So we're going to give you a few minutes. So about 54% routinely use, special circumstances in about 38%. Excellent. So it's great to see that we are utilizing this. So let's review how this can be helpful for us. So for those who just use it in special circumstances and those who don't use it at all, I'd really like to encourage you on the use, and we'll kind of talk through that. So let's go over. It's also called capnography. We say EtCO2. We also call it end-tidal CO2. So just know that we may use those interchangeably. So what is end-tidal CO2? Well, this is the level of CO2 that's released at the end of the exhaled breath, right? Now, it reflects the adequacy with which carbon dioxide is carried in the blood back to the lungs and then exhaled. So you're looking at that exhalation as the patient's breathing, what is exhaled. It can provide an indication of cardiac output. It can also provide an indication of pulmonary blood flow, and it can be very helpful with both of those. Normal is 35 to 45, so that is a normal CO2 level. And when you think about this, if a patient is ventilating too quickly, this will not allow enough CO2 to build up in the alveoli. So what that's going to do, it's really going to decrease our end-tidal CO2 levels. However, If they're ventilating too slowly, this will allow extra CO2 to build up, resulting in increased end-tidal CO2 levels. So you can imagine patients who are on medications that make them lethargic. We really want to be able to monitor them, especially those as well. This might not just be for the ventilated patient, but also for the non-ventilated patients, where we can determine how they're doing in their breathing and their pulmonary blood flow, and just to determine if we need to do a further intervention. EMS also utilizes capnography as a surrogate for lactic acid in detecting metabolic distress in sepsis patients. I know I have worked with our area, Putnam County, Tennessee, and those guys have end-tidal CO2 that they use, and they look at that number, and that is their surrogate for lactic acid. Now, end-tidal CO2 levels that are less than 25 millimeters of mercury strongly associated with a serum lactate level of greater than 4. So that's pretty a very easy way to monitor basically a surrogate lactate level, right? All right, so that's end-tidal CO2. We will add these variables in a few minutes to our case study. The next thing I want to mention to you is shock index. I don't know how many of you use shock index at your institution, but it's a simple calculation, and it's heart rate divided by systolic blood pressure. Now, what we found with shock index is that it's elevated. There we go. Elevated shock index predicts hospital admission and mortality. So it is a predictor of hospital admission and mortality. So patients with a shock index of greater than 1.0 from that initial emergency department vital signs correlated with a higher mortality rate. In patients transferred from the floor to like the MICU, the shock index of greater than 1 did not correlate with a higher mortality rate. So I did an example there for you. Patient's blood pressure is 105/40, heart rate's 128. You can see 128 divided by 105 is 1.2. Literally grab your phone, do the math, and then you're going to know right away, okay, this patient most likely is going to be admitted, first of all, and secondly, has a high risk of mortality. The next is diastolic blood pressure. I know some of these things seem very simple, but how many of us really take the time to kind of really evaluate systolic over diastolic, right? I've had people who you can go in, and then mean arterial pressure too. But sometimes patients, you'll go in a room and they'll have a pressure, systolic might be 100. And so everybody's like, hey, that's great. But the diastolic is so low that it's bringing down your mean arterial pressure. And those patients, they can be very sick. So don't just look at systolic, right? So if there is a diastolic less than 40 to 50, that is indicative. And let me add, with tachycardia, it's indicative of low vascular tone. And so I'll kind of do this in my mind as we're hooking somebody up. If I notice they have a really low diastolic blood pressure, then I will be like, I bet their total peripheral resistance is going to be really low, right? Because I know they're dilated out. So if less than 40 to 50 with tachycardia indicates low vascular tone, that is so important. If the diastolic is low, think vasodilatation. So that means your SVR, your TPR is going to be low. So we'll kind of talk through that as we do our case study. Another thing I just want to mention quickly, I didn't put a lot of information about central venous saturation, but I feel like it's one of those variables that we have really slowed down on utilizing, right? So central venous saturation, and one of the reasons we probably slowed down on using that is probably because we don't do nearly the central lines that we used to, and that's good. We don't want to have a patient have a line if they don't need it. But if you do have a central line that is either jugular or subclavian, and the end point is in the superior vena cava. So I've done this before on a patient with a PICC line, as long as that end point is in the correct spot in the superior vena cava, not a midline, right? So we draw a venous sample. Now we put it in an ABG syringe, and it is considered a tissue perfusion indicator. You do a venous draw, and normal's right around 70%. Now, there's a lot that you have to think about with that number. So let's say we have a patient who has a number of, it comes back at 48%. We are hypoperfused at the tissue level. That is very significant, and that's a bad day, right? So then we're going to go to what I like to say, let's chat about it. See, I'm going to look at cardiac output. What do we need to do to fix the cardiac output? I'm going to look at H for hemoglobin. If the hemoglobin is very low and we need to give blood products, that may be a reason why that number is low. A, arterial oxygenation. That's going to be if my FiO2 needs to increase because the patient's not doing well from a ventilatory standpoint, or maybe they need to be placed on the ventilator. And then T, tissue metabolic demands. If my patient is shivering, what can I do to decrease that shiver? If they have a temperature, let's get that temperature under control. If they have pain, give them something for pain. If they have anxiety, giving them an anxiolytic. There are a lot of things we can do to try to impact that central venous saturation and increase perfusion. And then let's get right into some of the other variables that you can now get with a basic, even non-invasive cardiac monitor, right? Excuse me, hemodynamic monitor. So let's talk about these first. Stroke volume. Stroke volume is my favorite. Stroke volume index. So normal stroke volume is 60 to 100, and that is the amount of blood that's ejected per beat. And with many of these monitors, if you enter height and weight, they will then also turn around and give you an indexed number. The 60 to 100 is the normal for stroke volume. Now, then you have what's called SVR, systemic vascular resistance, SVRI, systemic vascular resistance index, and then total peripheral resistance and total peripheral resistance index. Now, this normal here is for TPR and SVR, not for your indexed amount, but normal is 800 to 1200. These are afterload indicators. The question I always like to ask is are my patients' vessels dilated or are they constricted? If they are dilated, the TPR should be low. So when you start thinking about like extremely low diastolic blood pressure, I think I probably have a low TPR. And when I connect them to the non-invasive hemodynamic monitor, I can find out that, hey, that's really the case. I can validate that. And then how does this help us treat our patients? Well, if my patient is extremely hypotensive, and if they have a crazy low TPR or SVR, then I'm thinking they're very dilated out. We may think about giving them fluid, but we're going to check their responsiveness, but we may have to give them a vasopressor to constrict them or to bring that number up. So I just think that number, it is a calculated number. I've had doctors say before, that's a calculated number. We don't care about that. But actually, there's a lot of numbers that are calculated today, and they can be very helpful. And I find that to be a very number as well. All right, next is cardiac output and cardiac index. Normal cardiac output is 4 to 8 liters per minute. Normal cardiac index, 2.5 to 4 liters per minute. And cardiac output is that amount of blood pumped by the heart in liters per minute. Okay, so I like to think of it like this, levels of perfusion. And we're going to start with our first lever, which is preload. Now, when you think about preload, first of all, first and foremost, regardless of what lever, we want to make sure that our patient's perfusion is good, right? So we're going to start first with preload. I think stroke volume index, right? Normal stroke volume, think normal heart rate, 60 to 100. And then you can see your stroke volume index. We know that blood pressure is pressure, right? We know that pressure does not equate to flow. So we want to look at cardiac output too, which is heart rate times stroke volume, and that's more related to flow. Now, how are we going to determine if this is, if the patient is volume responsive? Some people say preload responsive. I'm going to say volume responsive. Well, we're going to perform a dynamic assessment to assess fluid responsiveness. And let me back up and just explain this dynamic assessment. And I think I have a slide a little later on that I'll explain this further. But you can do this one of two ways. You can do a passive leg raise, or and looking at stroke volume, when you'll start in a semi-recumbent position, the patient gets the baseline information, and then when the monitor directs you to, laying the patient flat, lifting their legs passively. The amount of volume in their lower extremities goes back to their heart. And if they have a 10% or greater increase in stroke volume, then the patient is volume responsive, which means their heart can take that fluid and help it pump forward flow and help with perfusion. Okay. The other thing, you could give a bolus, but the bolus has to be done very quickly. And it's just a small, it's not treatment, it's literally a testing. 250 over 5 minutes rapidly into that left ventricle to see if we have that same response. All right, if we don't have a stroke volume response, 10% or greater, then the patient is not fluid responsive. And now let's go to lever 2. Lever 2 is called afterload. Looking at that total peripheral resistance, R for resistance, or SVR if that's what you use. Total peripheral resistance 800 to 1200, SVR 800 to 1200. The lower the number, the more dilated. The higher the number, the more vasoconstricted. Okay, and then we're going to go to this contractility lever. Contractility, C for contractility. Cardiac output is 4 to 8. We already mentioned the normal for cardiac index as well. But if the patient has a low cardiac index, cardiac output, we want to ask why. We know that sometimes that can be low because they need fluid. So we're going to do a volume assessment or a fluid assessment test like I just mentioned. If they're not fluid responsive, then our next question would be, do they need an inotrope? Maybe this is related to contractility. I always like to look back at the echo. What is the patient's ejection fraction as well? And that should help us. All right. So now we've talked about the levers. We've talked about multiple variables, And now we're going to start with our case study. So we have Mr. John, who was at home, started running a fever. He began coughing and noticed at times he was coughing up a thick green sputum. He decided, or he thought he just had a cold, so he thought, you know what, I'm just going to sleep it off. I feel awful. I'm go to bed and sleep it off. 3 days later, patient's wife noticed Mr. John was not acting like normal. And she noticed also, she took his temperature. She thought he was burning up, took his temperature. He was up to 103 degrees Fahrenheit. So she called the EMS. On arrival to triage from EMS, the following was noted. Patient had a temperature of 103.5. Heart rate was 128. Respiratory rate 26. Blood pressure 105 over 40. MAP of 62. End tidal CO2 25. Shock index of 1.2. And end tidal CO2 of 24. All right, so we have a patient who has a known or suspected infection. They have multiple surge criteria and they have multiple organs down, right? They have actually cardiac down. Their MAP is 62. Their end tidal CO2 is only 25. And then we're going to go ahead and get some labs. So we'll go to this next slide. In ED, triage, patient was 5'11", 230 pounds. They noticed immediately the patient had a positive sepsis screen, so they urgently got him back to an ED bed. So kudos to them for triaging, in triage, doing that sepsis screen, really important. They started an IV. They connected him to the cardiac monitor that's reliable, and they placed the patient on a pulse oximeter and non-invasive hemodynamic monitor. Yes, in the emergency room. During this time of connecting the patient to the monitor, they got a past medical history of heart failure with an ejection fraction of 30% when he had his last echo. And they went ahead and gave him some Tylenol because of that high fever. Okay, sound like patients that you all have or have had? Yes. The provider saw the patient immediately and ordered the following labs and tests: a CBC, a lactate, blood cultures ×2 peripherally, And after they give all those, and all of those were ordered stat, the chem profile as well. After they got the blood cultures, they want them to give an antibiotic stat, and they did a chest x-ray stat and a urinalysis stat. The antibiotic that was ordered was appropriate for the patient's condition, and they based it on the patient's on the hospital's antibiogram due to a high suspicion of pneumonia. They did that stat after blood cultures, and I didn't want to list the antibiotic here because just depending on what hospital you're at, your antibiogram will help guide you for what those medications are. They'll be different probably for each hospital, or they could be. They also started an IV of balanced solution fluids, lactated ringers, 30 ml per kg to start. And the doctor ordered to do 500 ml increments with the dynamic assessments to make sure that the patient's volume responsive and that as he is receiving the fluid. So the provider really wanted to make sure we were aware of the patient's history of heart failure, but yet he knew how sick this patient was and felt like the patient probably would need fluid, but let's use our hemodynamic monitoring to guide our fluid status and how well they will tolerate that. Now, I just want to throw this in here. This is also a little free fun fact. New since just the beginning of July of this year, they say now that if for some reason a patient presents and the doctor feels like they should not have any fluid because the patient is not volume responsive, and meaning, in fact, I'm going to go to this next slide here, where it talks specifically about, and by the way, this is an example of what these poor abstractors have to abstract. They literally have so many variables they have to be knowledgeable with sepsis. And but one of the things, and I think I've got it on this next slide, and it's highlighted at the bottom, but if the patient has a ventricular assist device, or if they refuse, or if they have if they've done a passive leg raise or given a fluid bolus and the patient is not fluid responsive, you have to use a cardiac output, cardiac index, stroke volume, or stroke volume index. You can't just use blood pressure. I've had people say they use blood pressure. The sensitivity and specificity is not high enough to utilize it for that, but it's very high with stroke volume. So you can document that, but you have to document it well. It has to be specific based on the CMS guides, like what I have here, and then that will still count. So normally back in the day, it was that if you have a patient in the shock status, they have to get 30 mils per kg or you would fall out. So now they are giving us some leeway. And also, if the doctor feels like they should just have less fluid, they just need to document that, but they have to document why. If they're worried about heart failure, renal failure, they have to document why. Okay, and the other thing I just wanted to throw in here, this is still part of the free fun fact. I also want you to see, I did a sample progress note, one that I've worked on for the hospital I'm still affiliated with. And you can see we have specifically written out information for them so that they can make sure the provider doesn't miss anything, right? And we're in the process of making this part of the ER documentation as well. So really giving them guidance on how to give the fluid and how to document it. Okay, back to the polling question. And Monica, this is our final polling question. I'm going to let you take over for that.
Thank you so much. As a reminder, please make sure you're not in full screen mode in order to see and participate in the poll that is now appearing on the right-hand side of your screen. And that question reads, do you have the ability to monitor hemodynamics non-invasively at your current hospital? And it's a simple yes or no answer. So once again, do you have the ability to monitor hemodynamics non-invasively at your current hospital? Thank you all again for joining us, and we certainly appreciate you being here and participating in our poll. And I'll give it just a moment, and we will go ahead and turn it back over to Angela. Thank you.
Just giving you a few minutes to answer that. Thank you, Monica. So 67% do and 33% don't. So, okay, so this is going to be very awesome because most of you can do this at your hospitals. For those of you who don't, I'm sorry. I have been a huge advocate for non-invasive hemodynamic monitoring at my hospital, right? If you can monitor stroke volume, we need to, right? And also those other variables we talked about. Well, let's just quickly talk about just momentarily about some of the evidence about stroke volume guided fluid management, because I think it's important that you know I'm just not saying it's great because I think it's great. There's a lot out there in the literature about stroke volume guided care. So this was one study that was done in KU. It's the dynamic measures in sepsis. And basically what they did was they looked at a stroke volume guided resuscitation in severe sepsis and septic shock. And they found that it may actually improve outcomes. So they had a group in the stroke volume care and then a group in the usual care. Notice over here on the bottom right of your screen, the net fluid balance for the patients who actually had stroke volume guided care versus the usual care group. Notice the reduction in ICU length of stay in the stroke volume guided group versus the usual care. Same with less vasopressors, less mechanical ventilation, less dialysis. And another thing just to throw out there, only about 53% of the patients who are critically ill were volume responsive. And that's pretty standard. The literature shows that about only 50% are fluid responsive in the critically ill. So that's why we can't just guess, right? We don't really know until we do the test. Now, next is the FRESH trial, and this is called Fluid Responsiveness Evaluation in Sepsis-Associated Hypotension Trial. And basically, this was a randomized controlled trial. And they looked at, I know this is kind of a busy slide, but they looked at perfusion indicators like a decrease in mean arterial pressure, as well as low urine output, or patients who needed fluid. And they did focus on the sepsis population. And notice that these patients, they would do a passive leg raise. In the FRESH protocol, the FRESH trial, they did passive leg raises. And they did these as well in the emergency department. So it can be done in the ED. And notice if the patient did not have a 10% response in stroke volume, that they moved right to vasopressors. If they had a greater than 10% stroke volume change, then they went ahead and gave a fluid bolus. And then they would assess how are they doing. And after, if they had adequate perfusion, they would continue to monitor. But if they were still hypoperfused, they would do another passive leg raise to see how the fluid was affecting them. Now, so there are some great endpoints to the FRESH protocol, very similar to the endpoints in the KU study. So let's get back to the sepsis case study and let's see how we can better optimize this patient. So 1 hour after the triage vitals, the labs began reporting back. Notice we have a temperature of 102.5. You can see we're still hypotensive with a MAP of 61. Our heart rate is 110, white count 20,000, lactate is elevated to 6, BUN 30, creatinine 2.2, and the procalcitonin is elevated at 4. So here we go. You can see with the vital signs, now we have added the hemodynamic variables as well as the other variables we talked about earlier. Stroke volume is low at 42. We have a low stroke volume. TPR is normal at 957. Remember, 800 to 1200. Cardiac index is 2.2. So we are a little bit low here. End tidal CO2 is low at 24. And notice that is definitely a number to where we would think that lactic acid is greater than 4, and sure enough it is. Shock index is 1.3. So we all learned that means high risk for being admitted, and this is in the emergency room, high risk for mortality. This patient is very sick. Okay. So is the patient, I think the first question we always should ask, is the patient hypotensive or hypoperfused? We know they're hypotensive. We have a little bit of a low cardiac index, so we are going to assess this patient. Remember, I said you could do a fluid bolus, and it would just have to be very quick. So I recommend on a pressure bag, on an IV at 999 is not going to be fast enough to test that left ventricle. So we are going to start with a 250 over 5 minutes or 500 over 10 minutes, or you can do a passive leg raise. All right, so we did that. And here's what we came up with. Notice that we had a stroke volume increase of 14.3%. Our stroke volume went from 42 to 48. Most of your hemodynamic monitoring devices will give you that percentage, but it's an easy calculation to do if you want to do it on your own, but they usually will give those to you. So what are we going to do? My question to you, based on this clinical information, what should we consider next? And it's a pretty easy consideration. It's a pretty easy answer, right? Because we know they are fluid responsive. We're hypotensive and we're fluid responsive. So what are we going to do? We are going to give IV fluid. Okay, so we gave IV fluid, and we gave that 500 mils. So via rapid bolus. So then remember that provider wanted us to give it in 500 milliliter increments. So after the bolus was in, the following were the vitals. So you can see our mean arterial pressure is still only 53. Stroke volume still low at 45. Notice what happened in my TPR. It went down a bit, didn't it? So now I think to myself, I'm looking at this 40 diastolic blood pressure, and I'm thinking my patient is dilated, right? They sure are. We're only at 671. You can see cardiac index and output looks good, and tidal CO2 is still low at 26. My shock index is even worse. So what do we say? Is the patient hypotensive or hypoperfused? Absolutely. So they deserve a volume responsive check, right? So we're going to do another passive leg raise if we're able to. And notice at this point, I only had a 4.4 increase. So yes, after the first 500 they responded to, and now they're not responding anymore. So our question is, what should we do next? So based on our clinical findings, what should we consider next? And I want to remind you, we have a low mean arterial pressure, low stroke volume, low TPR, low end-tidal CO2, and high shock index. So for this patient, we are going to start a vasopressor. There would be no reason for us just to give fluid alone, because now this patient may still need fluid, but clearly without an increase in stroke volume, the patient's heart can't handle this right now, or is not going to be what they need for perfusion. So we're going to start a vasopressor. Norepinephrine is the vasopressor of choice for these patients. We started it at 5, and we're just going to say, since I don't know how everybody gives this at your institution, we're going to say we increase this over the next hour, and it maxed out based on your institution. Okay, so you maxed it out. So here's our question. Is the patient still hypotensive or hypoperfused? And I would say yes, and I think you would too. You've got a mean arterial pressure of only 60. You have a low stroke volume of 49. Now, what I do know and what I like to see is that this TPR is higher, isn't it? So that norepinephrine has improved, has tightened that patient up a bit, right? We still have a low end-tidal CO2 and a shock index is still high. So we're going to go ahead and do a passive leg raise again, or a fluid bolus. And lo and behold, we only have a 6.1% increase. Since our patient is still hypotensive and we're not fluid responsive, what might we want to do next? And for this patient, we're going to add vasopressin, right? So we added vasopressin. Pressors continued and blood pressure improved. You can see our mean arterial pressure is 66. Patient continued with monitoring. The patient continues on norepinephrine and vasopressin, and the provider asked the nurse to do another fluid responsive test to see if they could come down on the norepinephrine or if they need to give more fluid. And you know, it may not work to be able to take that vasopressor down yet, but I think the point of that is that we want, as quickly as we can, we want to start down titrating our vasopressor if we can, okay? So that just gives you an idea on how you can utilize hemodynamics at the bedside. Even in the emergency department, it can be done. I know it's such a busy unit, but it can really help to guide fluid and individualized care for that patient. So some of our key takeaway points for this talk today: You want to utilize a reliable cardiac monitoring system that gives you reliable blood pressure map, end-tidal CO2, et cetera, all those variables that we talked about. We want to always make sure, I never want to negate the power of a good, thorough physical assessment. And we want to utilize that physical assessment, there's synergy with that and with your hemodynamic monitoring system. Utilize a monitoring system to add to your assessment skills, to give guidance, to validate your actions, and use that cardiac output, cardiac index, stroke volume index, TPR, TPRI, SVR, SVRI, to better impact patient outcomes, because we know that's what's most important. And now I'm going to hand this back over to our awesome moderator, Dr. Susan Pyrus.
Well, thank you, Angela, for that most timely and definitely thought-provoking presentation. And I would like to remind the audience how they can obtain their CE for this activity. So this is a continuing education for nurses and respiratory therapists, and this activity is approved for 1 contact hour. To obtain your CE credits, go to www.saxtesting.com/BO. You will need to register at this site, complete an evaluation, and then upon successful completion, you will be able to print your certificate for completion. And again, support for this educational activity has been provided by Philips. If you would like to archive this, we have an archive version, and our archive demand version will be available to on better.outcomes.org. An email will be sent to all registrants when it is available. The on-demand version will be accredited for nurses and respiratory therapists. And at this time, we would like to look to our Q&A session, and we do have some questions coming in. We have a lot of content. And Angela, are you ready for some questions here?
Let's do it. Yes, absolutely.
Let's do it. Okay, so question number 1 is, do you use end-tidal CO2 at all to assess fluid responsiveness with the passive leg raise?
So you can, I'm not sure the sensitivity and specificity. Here's what I want to say. If you don't have non-invasive hemodynamic monitor, use what you have, right? Now fight for the other variables too, but definitely use what you have. So utilize that end-tidal CO2 to help you to determine pulmonary, to determine cardiac output, and use what you have. I am not sure the sensitivity and specificity of that with a passive leg raise. I would have to look that up, to be frankly honest, but I do know the highest sensitivity and specificity is more with stroke volume. But great opportunity. Utilize, I feel like end-tidal CO2 many times is highly underutilized.
So Angela, I know there's a lot of debate out there and between what exactly balanced solutions mean, and normal saline versus lactated ringers in these resuscitation. Can you speak to that, please?
Yeah. Sure, absolutely. So, I always back in the day, I just thought normal saline was normal, right? And now I tend to say abnormal saline, because it is not a balanced solution. The latest guidelines that just came out in 2021 for sepsis state that they recommend that we use a balanced solution. So balanced solutions are things like lactated ringers, Normasol, Plasmolite. Those are the 3 that I know of right off the top of my head. And so that is really, I think, where people are more going to a balanced solution. Now, if you do look at the literature and the research, the reason why they're suggesting balanced solution has to do with more of the renal component. So we're finding that some of these patients who have had high amounts of saline given to them, their chloride, they may end up with a hyperchloremia. It can affect, their kidneys. So I think it's important, if you wanted to give, saline. I'm not saying saline is totally wrong, but the guidelines suggest balanced solutions. So I would recommend going with what the guidelines say based on the research. But if you are a hospital that just your doctors are just adamant about giving saline, make sure you're watching their labs. And at the first, I mean, just be proactive. We may need to switch to a balanced solution.
Okay. Angela, do you know anything about, this is just a personal question, about the use of the widening and the narrowing of the pulse pressure with regards to as an indicator of what's exactly going on with the patient hemodynamically?
Yeah,
That
so tell
difference
me your
between
experience, Sue,
systolic
because
and
I know you,
diastolic.
yeah, so tell me your experience with that.
So I have found that when, in a patient with hypovolemia, that we kind of tend to have a widening pulse pressure. And then at the end of the shock state, we get into a more narrowed, less than 40. And has that been your
Yeah.
experience?
Yeah, and I think the literature, I'm sure you've seen that in practice, and I'm sure you've read that in the literature too. I think that's another variable or something that I really didn't mention earlier that we could look at as well, especially for people who don't have hemodynamic monitoring at the
Sure.
bedside. So yeah, I think anything we can do to aid in bettering our outcomes for our patients so important.
Absolutely. And that shock index, who do you see using that in practice? Because that was so easy to calculate, right? So easy.
So easy to calculate, and I don't know that many people utilize it. um I
Okay.
would think the focus for shock index more with the emergency department, because it really, I mean, actually you
Yeah,
can use it anywhere because it's so easy just to calculate. When it's really makes a difference is you're going to know right away if that's the case. When they present with that, mortality is most likely going to be high, and they're going to be admitted to the hospital. So, and I like to trend it. Like if you notice through that scenario, it was getting better. As we were
yeah.
perfusing, their shock index was decreasing. So I think that's a good, quick way of just saying, hey, where are we at on that trajectory of the shock index state?
Absolutely. So, some of the easiest things we have, we just kind of overlook. That was really good. It was a very, very
Mhm.
thought-provoking presentation. The case study just wrapped it up somewhere where we all live as patients in septic shock. It just, we just have to be aware of that this month. We're aware of it all the time as we practice, right? But this was a very good going through the patho, everything we know about cytokines now and how that's going on. So we'd like to conclude this time. And at this time, I'd like to turn the presentation over to Monica for some concluding remarks.
Thank you. Thank you so much. We certainly appreciate your participation and our audience today. I'm just going to wait. There we go. Angela is right back with us. Thank you for joining us. We do thank
So,
you for. Go ahead.
yes, thank you, Monica. And I'm sorry, I don't know what happened. It was just a quick little glitch. But one thing I wanted to mention, I am so lucky. I've gotten to work with Dr. Pyrus, who's faculty at a college, right? And I want to encourage people to work and reach out with your faculty. She also helps with publishing. We're about to publish our first article together. Super excited about that. But what that brings to a hospital, having faculty and PhD leveled faculty who can come in and really help your hospital emulate best practice, right? And then they also learn from us with what is happening at the bedside, and then can bring that back to the nurses to make it more real. So I just think a great opportunity I've had to get to work with Dr. Pyrus. And I just think it's a real win-win for both institutions and hospitals, right?
Absolutely.
Okay, back to you, Monica.
Thank you. Thank you both so much, and thank you to all of our attendees today. This concludes our webinar for today. I'd like to remind the audience that there is a survey for you at the conclusion that will pop up immediately. We would greatly appreciate you sharing your opinions on today's webinar. Thank you again on behalf of our presenters, Sachs Healthcare Communications, and our sponsor, Philips. We hope you enjoy the rest of the day. Thank you so much.